Good afternoon and welcome. It is my great pleasure and honor to introduce Dr. Michael Margolis today. Dr. Margolis has devoted his dental career to practicing healthy, holistic, biocompatible dentistry. As a member of the scientific group that got the CAVIT ultrasonic imaging team approved by the FDA, Dr. Margolis has been a leader in cavitational surgeries. As a graduate of Capital University in Washington and a doctor of integrative medicine, he has handled many complex dental cases in his career. Through experience, Dr. Margolis knows how important it is to keep impeccable dental records, especially in front of a dental board and also attorneys. Please join me in welcoming Dr. Margolis. Thank you.
Thank you. Well, good afternoon. I'll try to keep you awake because, you know, after lunch, you sit there and you go, just what I want to hear is record keeping. It's got to be probably the most boring thing anybody could ever look at until you're standing in front of your state board because the individuals that we get are not your run-of-the-mill individuals, think that they were wrong because they may have a pain, they may have a numbness, they may have greater expectations than what reality holds. So we're going to go over a few facts, and that is, we can get dental malpractice. According to a dentist benefit insurance company, 1.6% of dentists face a civil malpractice yearly. Average payout, $81,000. Plaintiff lawyers attempt to use a negative dental board result as a tool to leverage a settlement or civil lawsuit. These are public records. So what you find out is sometimes you get this ethical attorney, because we know all attorneys are ethical, will go through board results and pan it out and approach some of these people to see if they'd like to sue their dentist. And if you're in New York, California, Illinois, Arizona, and a few others, if you're a biological dentist, sometimes there's a little target on your back, and they start looking at those people and saying, hey, this is the guy we want to go for. So they look for the board complaint, a civil action can take place, and boards generally will tell you that your records are inadequate before they even see them. They'll tell you that the patient history, charting, x-rays, daily entries, and everything else, failure to refer to a specialist, lack of signed treatment plans or prearranged financial arrangements. And so they'll take that negative dental board result and use it against you, because as a dentist, if you get a result from a board that's not complimentary, you still have to sign it if you want to go back to business. So it's a business decision more than if you really agree with the board, and they're going to try to use that against you. So the legal worries go with the statistics reveal that you will face 3 to 5 legal actions in your career. Biological dentists, if you're doing cavitations and things like that and removing root canals, try to double or triple that. You'll have dental malpractice, civil cases, board cases, demand letters. So are you going to be next? Be prepared. So the importance of keeping daily records. Mr. Tanner is a dental advocate, and he's been in front of juries. The last case that he had, a gentleman died during the deliberations of the case. His traditional dentist just happened to miss his oral cancer. Now, I don't know how many of you will look in the mouth and check under the tongue, back in the retromolar areas, and down the throat, and see if that patient has cancer. Pull the tongue out, go back and forth, and feel along the sternocleidomastoids. If you don't do that, shame on you. Second, if you don't record it, it was never done. So you got to do two things. Not only do you have to look for these things, but you got to record it, because the juries said, if it's not in the chart, it didn't happen. If it's not in the chart, it did not happen. If it's in the chart, then it happened. Let's face it, there's no way in heaven that we're going to be able to put down everything that happened during that appointment. So, the first part over here, the front desk information and things like that, we're not really going to go over today because we don't have that much time. but you got to know responsible parties and things like that. The back office is where I'm trying to focus in on this, because it's your assistants that are going to seat the patient. They're going to take a blood pressure, and they're going to record it. So what you're going to have to do is follow a different system to see, or a system that you make up that is consistent, so you know the 5 principles of what you're going to have to do. But there are other important contacts. Your front desk could get a complaint that they are fielding, and the dentist never hears about it. And they never contact us, and sometimes you have a very good intentioned person at the front desk who says, well, I don't want to pressure the doctor, and they don't tell you. So in November, I had my left knee replaced. In December, I had a kidney stone surgery, and in January, I had a kidney stone surgery. Meanwhile, I had a patient file a concern with the front desk, and they never told me because they thought I was under too much pressure already. And then what happens? She turns around and files a complaint with the board because I didn't answer anything. I didn't even know about it. Prior to that, and it's reflected in her chart, she and I talked on the phone 10 different times on different things concerning her case, and it's a very strong thing to be able to put in front of the board and say, wait a minute, she could call me all the time, but she never complained to me, not once. So you want to have your telephone contacts, after-hour calls you want recorded, staff communication, notes in the record, insurance company contacts, consultation with other doctors, referrals to other doctors, make sure you got all their pharmaceutical scripts in there, letters, referral information, did they ever show up? And then the last part, which I find I do more and more, laboratory results with other doctors, because I do a lot of surgeries and I want to make sure that they can clot. So over here, it doesn't really matter. On the left side, we're showing that there's initial visit, restorative visit, crown and bridge, surgical, and whatever there is. That's brought forward from the front desk, and they're going to enter the patients in the computer, establish patients, any changes, responsible parties, insurance, health information and alerts. Did it change? And always put down if a patient missed an appointment. The back office is going to be looking at a whole bunch of things. Your initial exam is going to be different than your regular visit. You're going to have a date of entry. We're going to show you later on slide 14, a sticker, and it has health medical changes in your history. Ask a patient. The chair side should always ask the patient, what are we going to be doing today? Some patients are alert enough to sit there and say, well, if you don't know, I'm going to leave. But they should know what they're having done that day. Because if they think you're going to be doing a filling on number 5 and you're doing a crown or you're extracting a tooth, they're going to have their expectations way down to the bottom of the chart because they think you don't know what you're doing. And unfortunately, sometimes the front desk doesn't inform the back desk. So that way you can go in there and you repeat today's treatment, and if there's a different answer, put down that the patient was unaware that they were having a filling today. Is that okay with you, Mrs. Jones? And if it is, write it in the chart. Are there any other concerns that you want me to tell the doctor? Not only is that a very important question for communication, but that's your future income. Because you might have not known that they broke a tooth, or that they have another concern, they're grinding their teeth, or sleep apnea. All these different things go there. Take a blood pressure and record it. Get that in there. And then over here, take an oral screening every time they come in, except during a consultation. If they're in the chair, check it. Because as they were saying to the one doctor, if we have time at the end, I'll answer all questions, I promise. But at the end of your oral cancer screening, at the end of that trial that I brought up earlier, the patient died because the guy didn't look in the mouth and it was never recorded. It was a $1.8 million settlement because the man was dead. And the family got the maximum from the insurance company, and the doctor was responsible for $800,000. All he had to do is look, and he didn't. Any unusual events, and if there's something that occurs in the mouth or you see something weird, take a picture. Most of us have intraoral cameras. If you have mirrors and a good 35-millimeter camera, that's going to work because a picture paints 1,000 words. So course of action, signed treatment plans with fees listed, emergency routine. Treatment plan has been accepted, all payment arrangements been made. So the back office has got to make sure that all these things are done. Now, sometimes the payment's at the end of the appointment. When I'm doing surgery, we take the payment at the beginning of the appointment. And then the next visit's always listed, evaluate. Always have a next visit. In dentistry, there should never be a point in time that the patient doesn't have a next visit unless, one, they're moving out of town, or two, they're leaving because of one other reason like insurance or whatever. A sign-in sheet. These things are really important. You want a date, you want their name, responsible party, you need an adult to sign. And this brought up another thing that's not in this presentation that you should think of. If somebody is a minor, you must have permission, written permission by the parents if somebody else brings them in. So what we do at the beginning, when they go through their initial appointment, we ask who else might bring your child in who has permission to make decisions. And don't let them go out shopping during the appointment. We had a new patient come in, kid's 12 years old. We're doing their cleanings and everything. I go out to get the parents. They're across the street at the grocery store shopping. They're supposed to be there so we can ask questions. So that's really important. Time management's important for you. Time is money. So you want to know, are they on time? Are they waiting 30 minutes to be brought back? Any changes in any of their medical histories? Are we getting our patients back? And legal complications. Anybody have a family that ever gone through a divorce? And we had a parent complain that they said that they took us to the dentist, but they didn't really take them to the dentist. They're just trying to run up a bill. Well, we had the sign-in sheet from that day with the signature on it. And we also have routers or whatever. Routers is how we bill from the front to the back and back to the front and all that. So what's important is we were able to show the hand signature, time, and everything else in that situation. So here it is. You can get this, and I have, by the way, AGD disclaimer, I do not have any financial interest of a product in my talk or any companies offer me to grant money for this continuing dental and medical educational program. So you can go to Medical Arts Press, and those things rip off. You put it on the top of the piece of paper that you're sending back that you can take your notes so you can bill somebody. So it tells what time they come and you know when they're leaving. So over here, this is really a complicated form. We took labels for envelopes and they're printed out like this. Any change in your history. This is in the patient's handwriting. So we go through and we have a date. They say yes, no, print, and signature. And if the answer is yes, the assistant is going to talk to them when they're sitting them down. Oh, I noticed that you have a change in your health history. They print it out for me so I can read their handwriting. And then I review it. I initial that I reviewed it. And then I put down any changes I might do. We don't use epinephrine in any of our injectable anesthetics, but most people who have this, they sit there and say, every time I get a shot, my heart races. So then we can reassure them that there's no epinephrine. They feel a little better about that. So over here, this is what our form looks like, and it's a legal document. Up here, we want to make sure that they know who we are. We welcome them. How many times do you say thank you to a patient? They're a customer. They're paying your bill. They're putting your kids through college or paying for your new car. Thank them. Tell them that you're happy that to help them, they're here. Try to make sure that your office has a name and logo, something that sets you apart from the community. Then what you want to do is you got all the basic information for patients. Then you're going to have all the information for the responsible party. And in the state of Arizona, we have to put down, this is brilliant, all services provided by an Arizona licensed general dentist. That's the law. We have to have it on all our advertisements, and you have to have it in your treatment chart or patient information that you have done that. And their handwriting is all over this form. So we hit what the law is telling us we have to do. Most dental offices lose patients due to insurance changes or if they move away. Always record conversations with insurance people, telephone numbers, and person's name, customer insurance benefits, and stuff. So this gets a little tricky, so we did a form that basically shows how to do this. It tells you the waiting period, it gives you the patient's name, social security number, it tells you the effective date of their insurance. It says if things are covered, what deductibles, percentages. So you have a time and date. We turn this over for all telephone conversations. When we do the initial stuff, the rest is always entered in the regular chart. But we have their phone number, their extension, the person we talk to, and the notes of the conversation. By the way, the insurance company does the same thing with you. So over here, we have an insurance disclaimer, and this is really important when we look at this. Each fee is individual for an individual patient. So we do not render our services on the basis that insurance companies will pay our fees. We tell them there's going to be a copay and they might not cover everything. You are responsible. I can't tell you how many times people come in who, one, the insurance check is sent to them and they keep it. But we get a copy that they've gotten and we call them up and say, oh, we never got that. So we contact the insurance company, ask for a copy of the check along with their signatures on it, and we tell them you got 24 hours to come pay for this or we file a claim of fraud on your part. Some of these checks can be very hefty, and when you get 20 people do that, it can affect you. And, you know, we're rendering services directly to them. They are responsible for the payment. You have to have this in your form if you're practicing where there's insurance. So now we get into the medical treatment, and we're looking at serious illnesses in 5 years, all these other fun things, non-prescription drugs, and God knows most of our patients are on every homeopathic possible, and you want to make sure what they're taking. Record any information patient is receiving from a medical doctor. You may call the medical office and speak with staff or physician. When I'm doing surgery, I want to know a lot of different things, and bisphosphonates are a real problem. You know what I call a patient on bisphosphonates? The patient I'm referring to an oral surgeon today, because I don't want to deal with the complications. So you have over here for women, another fun thing, are you taking birth control? Got to check that. Are they pregnant or nursing? You get their height and all that stuff. Do you currently take or have taken bisphosphonate drugs? Had a woman come in. She was in pain after this terrible oral surgeon pulled out this tooth and it never healed. And we went through all our information, but we didn't have this one line there. And I said, what other drugs have you taken? And she already paid me cash for the service. And as soon as she said that she had taken Bonevia, I turned around and gave her back her cash and said, we can't help you. And we sent her to a naturopathic physician in Phoenix, Arizona, who works with bisphosphonate and other patients who are toxic from drugs, and they do detoxify these people very, very well. So it works nicely for them. And we also have this. If a woman is taking oral contraceptives, antibiotics may disable a birth control pill. I've had 1 or 2 women come in from other offices and tell me that they got pregnant even though they're on birth control, and they had this massive infection and they were on antibiotics. And like I said here, and just for your help, on this slide, pardon me, these are the names of all the bisphosphonate drugs. You should know these so you will be able to intercede on their behalf, but you do not want to be doing bone surgery on these people. And generally what we do is a CTX test, which my son, who's an oral surgeon, tells me is not reliable, but it shows the rate of bone being turned over and if they're going to heal or not. But you really want to be careful. As we continue with this, we have their health history, and you have to look at all the fun things that we always see, allergies, and we usually see a lot of people allergic to metals. Then over here we have the dental history, popping, clicking, your standard forms. And as we continue, we look at payment policies are clearly stated. Why do patients usually complain? Because it's expensive, and if they owe you money, sometimes they think they can get out of it, and this is why you do this. We're talking about changing the $25 charge for every half hour or $50 an hour, because that doesn't cover anything for you. But it tells you that you can have a finance charge of 1.5%, goes through everything here. By signing below, you indicate that you have read all the foregoing and understand the same and agree to dental services being rendered in accordance with the foregoing. So we basically have an agreement with them that they're going to pay for their service. So as we go, there are some 5 transitional steps from the front office to the back office that's going to help your doctor make sure that everything that you're supposed to do that day is going to get done, recorded properly, and performed correctly. So if you have an update on the history of the patient, you ask the patient, record update, any new instructions, RXs from their physicians. Ask the patient, why are you here today? Record their answer. Even if they got it right, they know that they're here for what's going on. Is there anything else bothering you? So that's possible for future work. If there are no other concerns, write down no other concerns today. Your boss knows, your doctor knows that you asked that question. Always have a blood pressure, pulse, and sometimes you might even have oxygen saturation. And then, I can't stress this enough, OCS, oral cancer screening, record results. And so, the 5 steps, come on, let's go, are done, and then all paperwork is filled out, entered in the office computer from the front, HIPAA, make sure you got those. Patient is taken back, x-rays, all medical. This is your front desk job to do, and now we're into the back office, initial office visit. Make sure you have a complete radiographic series. If your patients are concerned, there's a great homeopathic called radiation from Dr. Doc or something, and you give them 5 drops, it helps the radiation be peed out of the body, and it's called radiation. And they're a homeopathic drop, it's great. We take photos of the patient's face, smile, upper and lower arches and side bites. Why? Because if I'm going to do a presentation on them clinically later, I want to have good pictures to show before and after. And it's also very good to be able to show other doctors and boards what you've done. Oral examination is performed by dentists and or hygienists, or a combination of both. Record all missing, decayed, restored types of restorations. If it's a metal filling, we want to make sure that we have, if it's an amalgam or some other gold, we want that. What type of implants, any dentures, removables, any observable cysts, abscess, soft tissue abnormalities, and other conditions. If you take a look at a patient, you lift their lip, and on the frenulum you see this little tissue tag, you know automatically that they got a digestive problem. Take a picture of it. If you see a deep groove down the tongue, you know they got digestive problems. What is it when you look at the tongue and you see that it's scalloped? Is it a spleen deficiency? Could it be that they are a sleep apneic, choking to death while they're asleep at night, pushing their tongue forward, trying to get air in through their throat? And prior to starting work in the patient's mouth, have them rinse with mouthwash, get rid of some of those germs. It's really a great practice. Plus, it makes the patient feel a little better right off the bat. So oral exam is performed. Periodontal probing and classification of periodontal health, case 1 through 4. It's not that difficult. We were all taught this in dental school. Everybody should know it. Oral exam performed by the dentist. Oral cancer screening, maybe you've heard that before, is noted and recorded, either positive or negative. If there's a concern, many times what I'll do, in the last, so far this year, I've referred 3 people to a friend of mine who's an oral surgeon. He might not know how to take a tooth out appropriately in my consideration of removing the bone and getting the periodontal ligament out, but he certainly knows a lot about cancer. And so I send him over, we take a picture, we send the picture with the patient, we show where it's noted. Not only am I doing the right thing for my patient's health, but he's now liable and I'm not. So I like that. And so does he, because that's good business. So, what happened to you? We have a consultation discussion of findings. More information must be given to your patient. They might not understand the full scope. Explain or review blood antigen testing. I use Clifford religiously. It's something I've done since 1994. As a biological dentist, you may need to explain what you do differently than a traditional dentist. I've got a slide presentation that I do for about 20 minutes with each patient, showing what teeth do what to the body, so we have the tooth meridian chart. But I even go further back into the physiology and the structure of the jaw, the teeth, the periodontal ligament, the inner making of the tooth, how the odontogenic cells relate to the body, and I also talk about Dr. Steinman. And from this morning, you can see very clearly that tooth decay really is not tooth decay. It's a systemic disease caused by a change in the pH of the body or the terrain. And if you haven't looked that up, look at Dr. Steinman. It's really amazing what he's done. Over here, I have a disclaimer. I stand out. I'm different than a traditional dentist. The Arizona State Board of Dental Examiners, other dental boards, state boards, American Dental Association, the endodontists, the oral maxillofacial, the Academy of Periodontology, and North American schools do not agree that past extraction sites, root canal teeth, or ADA-approved restorative materials, dental amalgam mercury fillings, can be harmful to a patient's health. Dr. Margolis believes they are. So right there, I'm telling them I'm different. I had a state board ask me once, do you tell them that you're different? Not only do I tell them, sir, but I have a date, they print their name there, and the assistant signs the paper. They are in there at that time. There are no claims by treating any of these conditions will improve a patient's overall health. You can't say that. It doesn't work that way. We don't know. We have a pretty good track record. So here's an entry for a patient. We have the date. Mr. Smith states he is here for routine cleaning. His concern about losing filling in his lower left tooth does not hurt. So that's the change that he's concerned about. We have a blood pressure, a pulse. Patient presents for routine prophy, moderate calculus, lower linguals, generalized plaque. Patient states he's not been taking good care of his teeth, pocketing lower 4 to 6 millimeters. The patient does not like to get numb. So she went ahead and, without local anesthetic, just cleaned these 4 teeth here and the rest of the mouth, scale, polish, exam. After that, I should have put down that she had a laser treatment. He had a laser treatment. But we have no change in medical history, the date, he printed his name, and a signature, and then the hygienist's name goes there. At that point, I came in and we looked and I checked for the OCG, and then I saw that this is broken. We recommend a full porcelain or zirconium crown. Check allergies with 2 E's with Clifford and treatment plan. And you can use BioComp also, presented, accepted, and signed treatment plan. From there, we were able to schedule this. On the other page, other slide, I showed that he scheduled for a 3-week checkup, and then we did both at the same time. And then over here, we have a computer-generated thing. This is when it's presented. Here are your codes. These are the things: oxygen, a mask. We have a x-ray there, and then the procedure. We always put down that there's a buildup for every crown done. Rarely do I ever do a buildup. Usually don't need it when I'm doing full porcelain crowns, but I still have it in there in case I need to. And so I told them, this is the worst case scenario of what it's going to cost for that day on that tooth. So it's all presented to them. They sign the bottom. Here it is, the same treatment plan, describes the service, expense, and patient does not have insurance, so there was no problem of trying to figure out who was going to pay what. And then when they come back and we don't do a build-up at all, it's $300 less. They love you. And so we get the signature and everything's fine and everybody's happy. But on that, we have a consent form that Dr. Margolis and Dr. Kovar, my other doctor, is recommending that you replace existing restoration. Whenever an old restoration is replaced, the patient must be informed that there are risks, and we talk about nerve damage. We also talk about the tooth could have a problem with the nerve later, crown lengthening. We talk about the procedure there. There's a separate charge we talked to them about. Commonly reported reactions to local anesthetics. We talk about every bit of this with them. They sign it. and it just tells them that, complication can occur. So it's informed consent before the procedure is done. And so over here, we have this. We do not use epinephrine in patients' anesthesia. Well, if I get epinephrine, I have to go out of my room and get it in another room. So I'm pretty safe with that. Patients signed the treatment plan with consent, and then we went ahead and we used a rubber dam, separated IAOMT, mercury removal protocol utilized. And so he was dressed up, we were dressed up, and we prepared the tooth. Pentamix, we put in temporary temp phase, seated ultra temp, bite, adjusted bite, patient tolerated procedure well, C crown. Usually we get a little thing back, a sticker from the lab, and we put that in the chart saying the type of material that the crown is made out of. And then we have the doctor, whoever did it, will sign that. So it has the date, it's got his blood pressure, and we had a change in his medical because he had Azor due to an increase in his blood pressure. So it's doing its job, the pulse, the amount of anesthetic, and just go through the other thing, and everybody was happy. But we hit everything that we're looking for on those 5 different steps that I talked about. Patient said, I'm here to have a filling done. This is a woman called Anita Martini, and if you met her, you'd need a martini, I promise you. You have the date, you have a change in her medical history, and so patient has no other complaints, and I don't know why I didn't type in over here because I'm the one that types these slides. So we had to put in something there I got to find out what it was. We use a rubber dam, separate oxygen routine protocol, and then remove decay broken down. So we say what we're doing, EVO, tetric flow, EVO, composite, just bite, contours. I could have added in there, checked biocompatibility, and I'm going to go back and find out what the change was in there. And so next visit, always a next visit, because that's your lifeline of what's going on. We had the consent form that we went over, that she signed and dated. And then over here, Anita's treatment plan is clearly put out for the resin on 20. And so we have oxygen mask over here. We are going to be adding a fee for mercury safety because you have to clean the room, you got all this extra supplies, you're covering everybody, and so we're going to be adding that as a fee in the near future. Over here, do you utilize nitrous oxide or oral sedation? There are different things that you have to do for these different drugs, but record the start time for the nitrous, the rate of flow, and when it started and finished. Oral sedation requirements may vary between states, but you have to utilize a recognized protocol, record when you start the nitrous oxide amounts of medicine administered if Valium was dispensed the night before, and 3 or more recorded blood pressures during the procedure. That's from docs out of Washington State, and they have a very strict protocol, and you have to put the amounts and type of drugs that you've used. After initial appointments that are concluded, referral from a physician. I get a lot of physicians that refer. They have either a note or a referral pad they send to us. That's in the chart. We have the patient written health history. A lot of your patients, if you want to save time, since they're looking at a biological dentist, they have a history. They could tell you the day they had a filling done and when they got sick. So you ask them in their own handwriting or typed out nicely, preferred, and signed by them and initialed on each page their health history. It will save you a lot of time in your initial visit, and then you can start correlating. It's amazing within 18 to 24 months how sick people get after a dental procedure, sometimes sooner. So we have the full series x-rays, complete oral exam, including perio, case classification. I still have a cavitat. I was very proud of being part of their scientific team when we sent in our studies to the FDA, and they went ahead and used my dissertation on the cavitat, getting DNA or FDA approval. Any other relative testing that might be done and then a treatment plan is put together detailed, and we have a treatment plan consultation. During that treatment plan consultation, due to the nature of controversies with all these things, my office manager is in the room with me writing out the consultation on every patient. She takes notes as we discuss. After I leave, she does the financial with the patient, and we describe avascular necrosis as part of differential diagnostic term because cavitation and NICO is not recognized by the ADA or insurance companies, but avascular necrosis is. There's a CPT code for it, and it's accepted by insurance companies. Believe it or not, I even got paid by a place called Aetna Insurance for one of these surgeries because I called it avascular necrosis. And they actually paid me for a cavitat. Well, they haven't done that again. They actually called and asked me for the money back, and I said they had to call the patient because I didn't have a contract with them. Have you ever had that, an insurance company call you and tell you that they overpaid you? Anybody? I'm the only one? Yeah. You tell them, contact the patient, ask them to pay you back. I never hired you. And send a nice official letter with that. If they bug you again, get an attorney and put it on their letterhead. Because you did the courtesy of waiting for payment. And if they made a mistake, it's not your problem. And that's the personal story I wanted to say about that. It was amazing that these people did all those fun things. So on our treatment plan, we have a thing here. I advise them to go out, get a second opinion from another dentist or oral surgeon elsewhere. How many doctors tell you go get a second opinion before doing a procedure? Nobody. I also insist that they have another person bring them and pick them up from the surgery. And again, they initial and date that page. On the next page, we have that statement about the Arizona Dental Association and everybody else believes one way, we believe another. This is group one, this is the date, these are the codes, and then these are the teeth that we are going to be doing, and that explains the cost and everything. Dr. 1 refers to the myself, and T is the tooth where we're working, and description of the CPT. All these codes are ADA approved codes. Patient total charges, additional comments, customized are in here, and then we ask them to sign and date. So everything is well covered for you, and you should be able to go from there. But let's say the patient says, I don't want to do that. I just don't want to do your treatment. That's fine. I have no problem with that. This came out of an insurance company, and the patient has the right to refuse treatment. You just need to document it. So let's say you tell them, look, you got a broken tooth. A filling's really not what I recommend. They might only be able to afford a filling. I want you to say, I'll do the filling, but I want you to sign that you refuse doing a crown. Because in 6 months later, when you come back with that broken tooth, and I can't do anything but a crown, no, I'm not going to subtract the cost of doing that filling. And you're covered, and you document it. And it's okay if a patient says they don't want to do something. By the way, at the end of this, there's a source of where you can find those. Surgical consultation, additional consent and information forms. If you're doing surgery, these are all the possible complications. They initial everyone, and make sure they initial every single one. Sometimes they try to skip one on you, but you're going to get, you might get problems with anesthesia from a local injection. You have tooth extractions here, dry sockets, damage to other fillings, sharp ridges, incomplete removal, or tooth fragments. Sometimes when you're doing some of these things, you might miss something. You're still human. This last week, I took out a root that was huge. We even had an x-ray of the socket afterwards, and we couldn't find it. The body will push it out. You'll see it in a future x-ray. And yet, I thought I had counted all the roots. So I tell them that, yes, I put my shoes on like you do, anybody else, and you want to make sure they understand that. Numbness. This is amazing how people will sit there and say, well, you didn't tell me I could be numb. I have a friend, a $1.8 million lawsuit against him right now because the state board said, well, you didn't record this right. And yet they signed everything saying that they knew it. And I'm talking to the guy, I said, did you do this, this, or this? No, I didn't. Okay. So the whole fact of the matter was the patient went out and got consultations with 45 other professionals, of which one was a hydrocolon therapist, one was a shaman, and then a few other alternative people trying to get this done. And she saw 3 oral surgeons that said, what you need to do is have nerve surgery. Didn't do anything, went back and is suing the doctor for $1.8 million. That's crazy. And if you do cavitations and extractions of root canals, you know, you're going to get some sinus involvement. It's just the way things go. And then you have things to prepare, and after things are done, you don't hold anybody responsible until you want to sue them. You request perform following oral surgery presented to me in the treatment plan. In there, someplace it says if there's a complication, we have permission to take care of things. Had a patient who came in for oral sedation, second visit in for it. Her partner was with her. The first time, everything went beautiful. Second time she comes in, everything was going fine. Her partner said to me, can I give her a Tylenol? I said, sure, give her a Tylenol. She gave her a Tylenol 3. You don't mix barbiturates with a narcotic. Very well documented by us what happened. She went to the emergency room. I came back to my office 2.5 hours after we closed so she could get my anodyne light and a thing called a halo that helps things heal. They were fine with it and everything else. And then they got the bill for the emergency room, which I told them, please send it to us. We'll send a form to you and we'll pay the balance after your insurance, no problem. Instead, she didn't want to sign the paper saying that she wasn't going to sue me. And she turned around and filed a complaint with the board, asking the board for compensation for her suffering. And yet, it was her partner that gave her the wrong medication. And on the consent form, it was her partner that signed that part of the consent form because they knew she wouldn't be cognitive enough to be able to answer those questions and go. So it was quite interesting to sit back and look at what they did for me and tell me how wonderful I am, and then they turn around and they want to be compensated for her suffering. Amazing. So you go ahead and read that, and then you have the signatures here. So as we go along, what do you do when there's complications? Nobody tells you this. We tell it to them before, and if you look here, and if you looked at the first page, my cell phone number is on there. My email is on there. Even a mandibular block can cause nerve damage. Have a plan of action. In surgery, we have a plan of action. Now I have a 3D cone beam, and I can see where that nerve is. We outline it. We look at it from 3 different directions. I can tell a patient the probability of hitting that nerve and what we have to do to avoid it. So we're up front and try to get that all put together. So extra notes with telephone conversations, referrals to pain clinic or oral surgeons, keep record of healing progress, and have your patients sign your chart, give them a referral card, give copies of your mapping. What's mapping? Well, mapping is a really cool thing, which is after this slide, or 2 more slides. Good communication can prevent a board complaint, and if you get numbness, a Midral pack, yeah, it's a steroid, but boy, it shrinks things down and that nerve kicks back 9 out of 10 times. So, if you do a lot of surgeries, if a patient reports a numbness in their tongue, area of the face, after a dental procedure, such as injections, restorative, etc., document it. Get it in there. Get that person in there. Here's the form. Came out of Jerry Boco's old biopsy things. Record the affected area, draw it in the facial map, patient's name here, chief complaint. I even have the patient sign that. Tell me that they're telling me the truth. And then you mark it out. Here it is. This is where the problem is. Okay? And then you have all this fun stuff, the date, numbness, bingo, and then what do? You follow it up. And as you see, all of a sudden it shrinks. We're getting resolution here. After a month and a half or after a month, if it hasn't resolved to that amount, then refer them to an oral surgeon with the mapping. And they're going to sit there and say, hey, it looks like it's getting better. Let's just watch it through. Now, if you're looking for consent forms, dentistbenefits.com, risk management, I don't suggest using their amalgam replacement procedure one, but it's a good form if you put the IAOMT standards in there. And on the next page, there are some other forms there. But what's most important is that you have to remember this next slide. You have to remember, and I don't know why it says click to add title, it should have disappeared. Remember, the job is not finished until the paperwork is done. Sometimes I feel I have the worst job, yeah. I want to thank you for your attention today. Richard, thank you very much for giving me the opportunity to come in and do this. When we do the IAOMT initial training course, this lecture is actually another half an hour that goes into a lot more detail for individuals. But from personal experience, all I can tell you is you cannot add too many notes to your records. And don't ever be afraid to sit down and write them. When we do our surgical notes, we can't have the record in there. In fact, even when we're doing crown and bridge, we can't have the record in there. On the back of the router, many times we write it out, and then we go into a clean area and we rewrite the notes. And the patient's going to say, well, you altered your records. Okay, yeah, I altered my records for the safety to keep up with HIPAA and OSHA. So don't be afraid to do that. The more you write in dentistry, the better you are. My son is a physician, and he says the least we write in our records, the better off we are, because they just put the procedures in, and anybody who's a specialist knows what you're supposed to be doing. They don't get slammed as a general dentist would. And oral surgeons, they've learned to dictate. If we could dictate our notes, it'd be a lot better, because you'd be much more detailed. Or better yet, if you recorded the whole appointment on tape, but we don't. I've got, let's see, I think 46 minutes, so can I just take questions, because there's two hands here. Yeah.
As far as blood pressure, where do you draw the line? What's your blood pressure?
I have had people, and I've had people with 200 over 160 and still work on them. And then if you know your acupuncture points, where you go to the Hoku point, or you go motion sickness, and you just stroke the arm, I can generally get them down 40 points on that. Get them to relax. Some people, they walk in and see a dentist, their blood pressure's a mile high. My blood pressure going in, before I go in the office, I'm like 122 over 76. While I'm at the office, I'm like 180 over 90, because you can get tense. But when I'm out of there, I'm fine, and I recognize that. So if you're not using epinephrine, the patient's relatively healthy, fine. If they are with bad heart conditions and things, I'd think twice. I wouldn't go over 160, 180, over 90, 110. But then you got to feel the patient out themselves. Doug? Sure. Be more than happy to. Dentistbenefits.com. Dentistbenefits.com/risk _MGT. Yes.
One of the things that I find is hard is sometimes I'll give people several options. So one is do nothing, the other is do this, the other do a bridge,
Okay.
do an implant. How do you organize your different treatment plans?
Okay, the question is, many times you give patients options. The option of option 1, do nothing. Option 2, you can do a filling. Option 3, you can do a crown. You have in that case, 2 different treatment plans after you discuss. I've been doing zirconium oxide implants. I know a lot of people will say implants are terrible. And I take out, I don't know, up to 50, I think last year we did 55 titanium implants I took out, of which I've replaced better than half with zirconium oxide, and the patient hasn't had any problems. I can show case studies that I've done with that, and it's amazing. Had a guy come in, 57 years old, couldn't move his hand. Took out a root canal, titanium implant, and 2 cavitations. He was a patient for 3 years to 24 different physicians. 20 of them were our arthritis doctors. You couldn't touch his hand. I went to shake it, he went like this, don't touch me, I'll be on the floor. Being intimate with his wife was almost impossible. So the thing that happened was we took that out. 15 days later, he comes in, I'm taking the sutures out, he reaches out and takes my hand. But number 7 was removed, upper right 2, and after everything healed, I put a zirconium oxide implant in there, and he's fine.
What challenges do you experience with porcelain implants? Are you using one?
With ceramic implants, I use the Z system. I'm very happy with it. Same problems that anybody the question was, what problems do you have with it? Implants are implants. You have to have good bone, you have to have plenty of bone, and that's one of the problems that you run into. It takes experience to see if something's going to work or not. And I'd be more than happy to do a lecture on that another time, a breakout session if Rich wants that. Yes?
Have you done the 2-piece?
Yeah, the question is, have you done the 2-piece system? I sure have. The zirconium oxide now has a 2-piece system. Thing is fantastic. I love it. One of the first ones I did was a lower left. I did 20, 19, and 18. And we don't like the drill bits that they have because there's no stoppers. So I use a Husan drill bit system, but it's tapered. These are not tapered. So the first time I put one in, I crank it down, crack the implant because I went too high on torque. Being bright like I am, I do a second one after I get that one out and do the exact same thing. And my assistant goes, Doc, before you start scratching your head and pulling any more hair out, because obviously I've done that plenty, we found out that we drill to depth, then I take their drill and make it cylindrically even all the way through, then I don't get the breakage. But there's a learning curve with everything. And the good thing about that is you don't have to worry that the patient's tongue is going to knock that out. And there's another whole system that I go into in the other class of how to record how you do your implants. Everything is systematic. If you just make a system and keep it consistent, your boards are going to love you. It's easy to read. It's simple to read. And you can find everything on your notes. Yes?
What pants he's gonna wear?